kemana-mana.
Pesertanya terus pundi, Dok Nana?
Pesertanya ini tanpa mendaftar, Prof. Jadi
nggak maksud saya mungkin sudah ada yang join gitu, mungkin dibantu opera-opera nanti adik-adik.
Nanti saya share ke mahasiswa, Prof.
Ini masih di breakout room ya, Nana ya?
Masih di room.
Panel room ya. Saya belum tahu gurunya. Apa?
Ini narasumbernya sudah masuk, saya masukkan nggih. Saya admit nggih, dokter-dokter sekalian.
Silahkan Dokter Mirsa supaya.
Nggih, baik.
Hello.
Halo, Dr. Farah.
Hello. How are you?
I'm fine. Thank you for coming in our faculty.
Thank you. If my voice is clear?
Yes, your voice is clear now.
Okay. I have some issue with the internet. That's why my video may be interrupted, or I tried. Hello.
Okay. I will introduce you. Dr. Rimayanti is a Vice Dean from Airlangga University. And
Assalamualaikum, Farah.
Waalaikumsalam. How are you?
I'm fine, thank you. And how are you?
I'm fine, thank you.
Nice to meet you, Farah.
Same here.
And I will introduce you Professor Wiwi Misako. She is head of Division Clinical Science, Veterinary Medicine, Airlangga University.
Okay.
Good afternoon. Assalamualaikum warahmatullahi wabarakatuh, Dr. Farah.
Waalaikumsalam warahmatullahi wabarakatuh. How are you?
I'm fine. Nice to meet you.
Thank you. Same here.
And there are some lecture from clinical science, Dr. Nusdianto, Dr. Dr. Kiki, and Dr. Ira, and the last Dr. Mirsa.
Okay.
Assalamualaikum, Brother Farah.
Waalaikumsalam. How are you?
I'm
Waalaikumsalam.
fine. Very nice to meet you.
Same here. Thank you. Sorry, I have some throat infection. Maybe if my voice is clear to you, you can listen clearly.
Yes, very clear. We can listen you
Okay,
clearly.
then okay. Okay, can I start now?
Okay, before we start, let me admit the participant. So the participant is still in the waiting room.
Okay.
Ini tanpa mendaftar, Prof. Jadi, nggak maksud saya mungkin sudah ada yang join gitu mungkin
Some
untuk opera-opera adik-adik. Nanti saya share ke Mas. Ini masih di breakout room ya?
Iya, sampun masuk 139.
Female cafe.
Okay, I think all the participants already joining for today's session. So I think we can begin this today's session. Okay, good afternoon all. Assalamualaikum warahmatullahi wabarakatuh. Inge, silakan.
Supaya
Inge, apakah bisa dimulai?
Ma'am, I can listen you clearly, but not other participants.
Oh yeah, the participants' microphone will be only unmute if they have any
Okay.
question or only in
Okay.
two-way discussion.
Okay, thank you.
Or maybe you want the participant to unmute the microphone?
No, at the end of session in discussion,
Oh,
that's
okay.
more convenient.
Okay.
Okay, tell me when I have to start.
Hello, how are you? I'm fine. Thank you for coming in our faculty.
Thank you. Is my voice is clear?
Yes, before, okay, if it's all okay, yes.
With the internet, that's why my video may be interrupted.
Okay.
I tried.
Hello, okay, okay, it's okay. Bisa dibuka dokternya sudah atau belum?
I will introduce you. Dr. Ibayanti is Vice Dean from Erlangga University. And Farah.
How are you?
I'm fine, thank you. How are you?
I'm fine, thank you.
Nice to meet you, Farah.
Same here.
And I will introduce you, Professor Lady Isako, Clinical Science, Veterinary Medicine, Erlangga University. Good afternoon, Assalamualaikum warahmatullahi wabarakatuh, Dr. Farah.
Waalaikumsalam warahmatullahi wabarakatuh. How are you?
I'm fine. Nice to meet you.
Thank you. Same here.
And Dr. Ira, Dr. Lisa.
Hello, good afternoon. Assalamualaikum.
Waalaikumsalam.
Okay, so all the participants are already joining, and Dr. Farah is already here.
I have some problems.
Okay.
If my voice is clear to you, you can hear me.
Yes, very clear, Dr. Farah. Okay, so good afternoon all. Welcome and thank you for joining.
Let me admit the
Okay. Yeah, it's
the participant is still in the waiting room.
okay. Ini sampun masuk 139. 203 di tempat saya, Dok. Ya. Apakah bisa dimulai, Dok Nana?
Ya, monggo Dokter Mirsa.
Okay, good afternoon all. Thank you. Welcome. Thank you for joining today's guest lecture event about orthopedic surgery in pets with internal implants with Dr. Farah Ijaz. So before we begin the lecture today, there will be a welcoming speech from the head of Division of Clinical Veterinary Science, Professor Misako Yuniarti, and also a welcoming speech and will be opened by the Vice Dean of Faculty of Veterinary Medicine, Dr. Rimayanti. And today's lecture will be, the moderator is Dr. Hardani Primariski. So the first is welcoming speech from the head of Division of Clinical Veterinary Science. Already joining for today's session. So I think we can
Okay, thank you, Dr. Mirsa. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Respected for First Vice Dean of Faculty of Veterinary Medicine, Dr. Rimayanti, our honorable guest speaker, Dr. Farah Ijaz, today event person in charge, Dr. Irasari Yudaniayanti, and all participants. Today, on behalf of the Division of Veterinary Clinical Science, I welcome you all to this online guest lecture program and might want to widen a note of much appreciated. All of us know that in veterinary practice, orthopedic case sometimes need a surgical approach. Depending on the case, there are many techniques and tools that can be used in bone fixation to solve the problem. And we know every veterinary surgeon has their own technique and trick in solving the case. And today we have an opportunity to learn further about orthopedic surgery using internal implant from Dr. Farah Ijaz.
Okay,
She's come from University of Veterinary and Animal Sciences from Lahore, Pakistan, who is known for her expertise in internal implantation. Welcome and thank you, Dr. Farah Ijaz, for willing to share the knowledge about this topic. Through this event, we hope that our students can broaden their knowledge and gaining a new perspective on orthopedic surgery by learning from experienced invited speaker. So be enlightened and have a wonderful class with us and Dr. Farah Ijaz. Thank you. Thank you, Dr. Mirsa.
Okay, thank you, Professor Wi, for the welcoming speech. So next is opening and welcoming speech from the Vice Dean of the Faculty of Veterinary Medicine, Dr. Rimayanti. Please welcome Dr. Rimayanti.
Thank you, Dr. Birsa. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Before we start, let us praise and thanks to Allah Subhanahu wa Ta'ala for the abundance of His grace and the joy to all of us, so we can still gather this afternoon in such good health. First, I would like to welcome Honorable the Head of Veterinary Clinical Division, Faculty of Veterinary Medicine, Universitas Erlangga, Professor Dr. Misako Yuniarti. And then as well as welcome to our honorable guest lecturer today, Dr. Farah Ijaz from Faculty of Veterinary and Animal Sciences, University of Veterinary and Animal Science, Lahore, Pakistan. Welcome in the virtual classroom of Faculty of Veterinary Medicine, Universitas Erlangga, Surabaya, Indonesia, for Dr. Farah Ijaz. I would like to welcome our honorable lecturers and students of Faculty of Veterinary Medicine, Universitas Erlangga, who might join the guest lecture this afternoon. It is my great pleasure to welcome all participants who have joined the guest lecture today in the virtual classroom of our faculty. Today, we attend a guest lecture, a speech about orthopedic surgery in pets with internal implants through Decota program of Universitas Erlangga. We know that Decota stands for video conferencing with Universitas Erlangga. Decota is a part of Erlangga Global Scholars, which aims to attract global scholars to give lecture to the students of Universitas Erlangga by particular online platform. The program involves any international academics from a university or institute of higher education who deliver an online course to the students of Universitas Erlangga. Even though these lectures and transfer knowledge are given online, hopefully we can learn a lot from the lecture session and we will have interesting and stimulating discussions. I encourage all of the students to ask questions and discuss about this interesting topic. There is a blessing in this case in this pandemic situation because we have made the online teaching more interesting by featuring guest lectures from other universities around the world. And of course, make it easier to us to attend the meeting online without any obstacles of space and time. I would like to thank the head of Veterinary Clinical Division, Faculty of Veterinary Medicine, Universitas Erlangga, Professor Dr. Wiwi Misako Yuniarti, and all of the lecturers in the division, as well as Dr. Adiana Mutamsari as a faculty ambassador for organizing this event. And of course, special thanks to our speaker today, Dr. Farah Ijaz from Faculty of Veterinary and Animal Sciences, University of Veterinary and Animal Sciences, Lahore, Pakistan, for delivering such important and interesting topic so we can deepen our knowledge. We really appreciate that, Dr. Farah. Finally, I sincerely hope all of the participants will enjoy the lecture, and I wish the program will be fruitful for all of us. Thank you very much. And Bismillahirrahmanirrahim, the guest lecture program is officially started. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Mirza.
Okay, thank you, Dr. Rimayanti, for opening this lecture today. So this session will be moderated, the moderator is Dr. Hardani Primariski. Dr. Hardani Primariski is already joined, Doctor?
Yes.
Okay.
Dr. Mita, I'm here already.
Dr. Hardani Primariski is one of our lecturer in Division of Veterinary Clinical Science. And the guest lecturer today is Dr. Farah Ijaz. So we will not waiting for long anymore. So we will begin the lecture today. Please, Dr. Farah Ijaz and Dr. Hardani Primariski.
Okay, thank you, Dr. Miza. Good afternoon, dear lecturers and students. In this very brightful day, we would like to have a guest lecture that will be conducted by Dr. Farah Ijaz. Maybe I would like to say hello first to Dr. Farah. Assalamualaikum, Dr. Farah.
Waalaikumsalam.
Okay, how are you today?
I'm good. Thank you. How are
I
you?
hope you are in a very healthy condition, yeah, doctor. May I know what time is it in Pakistan right now?
11 a.m., 11:20 a.m.
Oh, okay. So we are saying thank you for your participation on this guest lecture and your willingness to give or sharing the knowledge to us. So to all of the participants, before we started the presentation from Dr. Farah Ijaz, I would like to give you information about her curriculum vitae, the brief information about Dr. Farah. Dr. Farah is having experiences more than 4 years experience, yeah, especially in surgery. And then she started the education of Doctor of Veterinary Medicine in year 2007 until 2011 in the Gomal College of Veterinary Science, Gomal University, DI-Han, Pakistan. Her subjects that undertaken is animal husbandry and veterinary medicine. And then in 2011 until 2013, Dr. Farah Ijaz has been doing her master degree in University of Veterinary Animal Science in Lahore, Pakistan. Her major is surgery. In current time, right now, she is in charge in radiology department and then working as a lecturer of the surgery subject in University of Veterinary and Animal Science, Lahore, Pakistan campus. Based on her curriculum vitae, a lot of the activities that she's been doing, and her professional technique in hands that have been her expertise, such as surgical technique, radiological technique, ultrasonographic technique, sample collection, or serological, microbiology, and molecular technique. She also achieved a lot of awards and then has been participated in a lot of international forums. And then she also already published a lot of publication, especially internationally, in a lot of international journal. And then she also having participated in a lot of international conference and already published her project or her study in some of conference paper. And then last, she also have an extension articles that maybe all of the participants can look at or look for in the internet. Yeah. So I think we have no doubt about her experience, and then we hope that this afternoon we have fit condition, yeah, to listen all of her presentation. And then to Dr. Farah Ijaz, I would like to inform you that we will give you time to present the topic entitled Orthopedic Surgery in Breast-Built Implants, about 1 hour or 60 minutes. And then after that, we will continue with discussion session. So, Dr. Farah Ijaz, are you ready now?
Yes, I'm ready.
Okay, so please present to us your topics, and then maybe you can share your presentation now. Thank you, Dr. Farah.
Thank you. Yes, as I already mentioned, I'm going to today's lecture about orthopedics. Can you see my screen now?
Yes, we can see.
Yeah. So firstly, I think I will recall some knowledge so that for further studies, it will be convenient for us to. Okay, first of all, orthopedic surgery, definition of it. In this, we deal with the preservation, restoration,
Excuse
and
me, Dr.
development.
Farah. Sorry to interrupt
Yeah.
you. Maybe you can try to change the view in the slideshow. So maybe we can see it better. Yes.
Is it okay now?
Okay, thank you, Dr. Farah.
Okay. My voice is also clear?
Yes, your voice is very clear. You may continue.
Okay. First of all, what is orthopedic? in orthopedic, we deal with the fracture or bone. Firstly, I say we deal with the bones, then joints, and any kind of problems or any kind of functional deformities with it, like preservation of that, restoration of that, development of formal function of different limbs, and physical changes or surgical changes in this. Main is we deal with the bones and the joints. So first of all, parts of bones, we know that epiphyses, the extremities, there are epiphyses, then diaphyses, and growth plates. I am recalling this because I want to elaborate about fracture and its types. So that, what is fracture? Any discontinuity in bone or its cartilage is called fracture. What are types of fracture? Fracture of long bones result from different forces applied on that. They will be bending forces, due to which we have transverse cracks on tensile sides or long bones. Sometimes we have small fragments due to bending forces as they bend the bones in on their axis. The other one is axial compression forces or bending forces. They causes detachment of big pieces of bones like butterfly fragments, which have many compartments, or compressive sides of bones, they called fractured. Axial compression, these forces of causes oblique type of fracture. Then torsional forces in this, they have spiral movement of the limb or the bones. That's why they have spiral type of fracture. Tensile forces, due to which transverse fractures or avulsion fracture, in which small fragment of the bone or attachment of the bone is detached. High energy forces or comminuted, due to which comminuted or multiple fractures are caused. Others are pathological fractures. These are due to different kinds of diseases, due to which bones are weak, or a demineralization affects the bones and they cause fracture due to weakness of the bone. Here are some forces which are discussed in figure form. Due to bending forces, the bone bends on its axis, due to which transverse, same like this, fractures. Here is a line, black line, which shows fracture. And next, again, bending and compressional forces, they cause, I say, butterfly like fractures. We say butterfly, the wing of butterfly. Here we can see that same, or it causes a big piece of bone to be fractured. Then axial compression, in this long oblique fracture, they may be long oblique or short oblique. It also depends upon the forces which affect on that. Then torsional forces, which rotate the bone on its axis or in circular form, due to which it breaks in spiral form. Here we can see in the near cortex, or we see the cortex on our side, then these dotted lines shows fracture on the opposite sides, and it then turns along our side. It is S-like fracture or spiral fracture, that's why it is called. And if high energy forces like some trauma or accidental cases is called, it causes multiple fractures or have multiple fragments. In this we can say have many soft tissue damage, or which I discuss again further. But here, if high energy forces affect, it causes multiple fragments. In the figure E, we can see what kind of fracture it can cause. Classification of fractures on the basis of presence or absence of communicating wound, the wound which communicates to the external environment. Then also classify fracture according to the damage to the bone or surrounding soft tissues affected. We can also classify on that basis. Also classify on the basis of direction of the fracture line, and also on the basis of fracture fragments, position of the fragments according to its epiphysis, and the site of fracture, where the fracture occurs. First of all, on the basis of presence or absence of communicating wound. It is divided into two classes. One is closed fracture and other one is open fracture. Which fracture we can say it is closed fracture. Closed fracture is that fracture in which the skin is intact. No, we can say we can't see any kind of wound on the skin, but the bone is break or bone has fracture, but skin has no damage on the external side, or any layer of skin have no effect. That is called closed fracture. In this, they have no, we can also say they have no connection to the external environment. That is closed fracture. And if it has a connection or communicate with the external environment, or the skin over the bone is also damaged, then it is called open fracture. Soft tissue damages in both cases, but skin damages in one case, in open fracture. Mean bone breaks and it comes out of skin, then it is open fracture. And if it remains within skin or within that specified area, it is called closed fracture. The other is open fracture classification. Open fracture is further classified into 5 types according to the incision, according to the window or the opening it causes. In type 1, small laceration we already know. If any irregular wound occurred is called laceration. Then if small laceration less than 1 centimeter, it is type 1. It is mostly clean. It has no too much effect or too much we can say connection with the external environment. In type 2, more than 1 centimeter, large laceration, it have mild soft tissue trauma, or sometimes some we can say soft tissue have damage, like muscles or subcut tissues have damage, but no flaps or flaps of skin or muscles are occurred, or no any piece of them is separated. That's why it is type 1 open fracture. In type 3, type 3 is further divided into 3 categories according to the soft tissue damage. In first one, soft tissue lacerations with skin is called, but have small flaps or we can say small fragment of skin is damaged with the minor effect to the soft tissues. But if it has extensive damage to the soft tissues, like some flap of muscles or bone, skin is separated or exposed the bone, then it is called type 3B, and it is stripped away from the bone. Like periosteum is also exposed, but in the type A, just a flap is present, but not too much. But in B type, it has strip periosteum is also damaged, and it is separated from the bone. In type 3C, also it affects to the blood circulation or blood supply of that area or that bone, and it also causes to some kind of damage to the limb. Maybe animal have too much limb damage that it can't bear any kind of weight on that. In fracture, sometime if mild, then they can put their foot to the ground, but in type 3 they can't put their foot to the uh, ground, and they just hang it up. That is type 3. In type 4, too much damage to the limb, I'm saying limb because the area beneath the fracture is almost dead, or too much damage. We can say too much damage, that amputation of the limb from that area is required. It is type 4. It is mostly cases, this kind of mostly cases I have seen in roadside accidents, in which we can't repair to the injured parts, or we can't repair the soft tissue damaged, or they have too much damage that they can't be repaired. That's why we have to amputate that limb. It is type 4. Then the other category, on the basis of extent of damage to the bone and surrounding tissue, the fracture is further divided into incomplete and complete fracture. Incomplete fracture. Incomplete fracture in which the cortex of the bones are not involved. Just one cortex is involved. Cortex, I'm saying side of the bone. Just one side of the bone is involved, and the other side is not involved. It is further divided into green stick and hairline. Green stick is, if I go back on the diagram, if the just one side, if that area of the uh, bone is damaged, but this here the V-shape area is intact, there is no damage in that area, then it is green stick. And if a break like that just on one side is hairline, mean if this side and this side both are involved is called complete fracture, and if one side is involved, just fracture in one side or in one plane, it is called incomplete fracture. Complete fracture. Complete fracture in which both sides are involved. Then single fracture in which bone is break into two pieces is called single fracture. Mean overall bone is divided into two pieces. Then multiple transverse fracture is type of this kind. Single fracture, multiple or segmental fracture where the bone breaks into more than two pieces. They may be one or two pieces, then we can say it is butterfly or wedge shape. But if more than two pieces, then it is segmental or multiple fracture. Again, it depends upon the damage to the bone and surrounding tissue. Further, I say tell about surrounding tissues. Comminuted or multifragmentary fracture, in which the bone breaks into more than two pieces, along with the area or the soft tissues surrounding it, they are also damaged. Then it is comminuted with multiple fragmentary or complex fracture. It have many fracture lines. The pieces also have further fracture lines. If they have a 1 centimeter piece, then it has some more hairline fractures or multiple lines in it. Then it is multiple fragmentary fracture. Complicatedly the fracture, when nerve or blood vessels in that area is also damaged, then it is called complicated fracture, because the damage to that area is too much or extensive. That's why it is called complicated fracture. Impacted fracture, when the parts of two bones are impacted in it or merged into it, then it is called impacted fracture. Can you see my video? I don't know if my video is clear. Impacted fracture is same like that. If you can see my hand, in impacted fracture, here are two fragments of bone and they merge into itself. They impact on themselves. Then it is called impacted fracture. Wedge fracture, which is a multifragmental fracture with some contact between the main fragments after reductions. When they are reduced, they have some contact with the other fracture types, then it is wedge fracture. After especially restoration or after we immobilize them, on the basis of direction of the fracture line, it is divided into transverse fracture, oblique, spiral type of fractures. Transverse fracture, it is again same like single layer fracture, in which the bone is separated into two pieces, but on the transverse plane, in the straight line, right angles to the bone or long axis of the bone. It is called transverse fracture. Oblique type. In oblique type fracture, the bone is break on oblique angle of its long axis. Then it is called oblique fracture. Oblique fracture is further divided into long oblique and short oblique. Long oblique, if the angle is too long, and short oblique, if the angle is short, then it is long oblique and short oblique. Mean if the diameter is twice the diameter of the bone, then it is long oblique, or if less than this, then it is short oblique. Spiral fracture, I also explain it in at start, that when bone has twisted angle on its whole axis, then it is called spiral fracture, or it has S-shaped fracture. Then other is on the basis of position, on the basis of position of the fracture fragments, on the basis of position of the fracture fragments, the fracture may be overriding, distracted, and avulsion. Overriding fracture. When the distal fracture fragments overrides the proximal one. When a fracture, if you have long oblique fracture in your mind, then I elaborate that overriding fracture is that when distal fragment or lower fragment override the proximal one, then it is overriding fracture. Normally seen in distal shaft of mostly seen in the femoral fracture or long bone fractures. It is mostly seen in long bone, especially femur and humerus. They have overriding type of fractures. They need more uh, power, or we can say more force to pull them back on their normal contour, as sometimes they merge into or they affect the muscles surrounding them. That's why they are overriding type. Then is distracted fracture. In this type of fracture, the proximal fragment is pulled away from the other fragment in uh, in any direction. Mean distal fragment and the proximal fragments are pulled away from each other. The gap between them is extended or too much, but they are still in the same plane. This is distracted fracture, as from its name indicated. Avulsion type of fracture. In this type of fracture, any insertion type of muscles, tendon, or ligament is detached from the other part of the bone due to any kind of force or forceful pull. It is called avulsion fracture. Here I say avulsion fracture of tuberculosis calcis. Here is fracture, and this piece is avulsion piece of that bone. On the basis of the site of the fracture may be proximal and distal. Segment fracture like type A, it have type A and type B, extra-articular and partial articular. When the articular surface is not fractured but is separated from the diaphysis, these are typically called metaphyseal fractures, such as supracondylar fracture. Here I have its a radiograph. Supracondylar fracture, in this articular surface is detached from the other surface, and it is called supracondylar fracture. Normally it is in transverse plane or on the long axis of the bone, just above the condyles, like here on the diaphyseal growth plates. Mostly this kind of fracture occur. Type B, partial articular fracture, when only part of the joint surface involved with the remaining portion still attached to the diaphysis. It may be unicondylar or bicondylar. The most common example is fracture line partially passes through the articular surface, the joint. If the fracture lies or fracture is till the joint or articular surface of the bone, then it is partial articular fracture along with growth plates. Type C fracture, in which the joint surface is fractured and is completely detached from the diaphysis. It is type T or Y. Its shape is T or Y. It represents the type according to the fracture line, and it has also disruption in articular surface of the bone. Diaphyseal fractures, when the fractures occur in the diaphyseal region of the bone, it is called diaphyseal fracture. but the fracture in these areas need more time for healing due to distraction of the diaphyseal or growth plates. Here are some types. In A and B, we have first one, type A, extra-articular, while in C, we have partial articular, in which joint surfaces or articular surfaces involved along with growth plate or physical growth plates and also some part of metaphysis. While in type C, it has, we can see T-shaped fracture in the epiphysis. Here also more clear, here is Y-shaped fracture with, in this articular surface is also involved. Articular surface of bone is where the joints are attached, or when the surfaces on with connected with joints are articular surfaces, then its growth plates are here, and then some part of their metaphysis also involved. It is Y and T type fracture. Then the most common type of Salter-Harris type of fracture. These are physical fracture or fractures in the physis of the bone, especially on the articular surface. Again, the near the joints are called Salter-Harris type of fracture. They are of 6 types. In type 1, just epiphysis is separated from the metaphysis at the area of growth plates. Here we can say metaphysis, physical growth plates, and epiphysis. In type 1, the epiphysis is detached from the metaphysis with growth plates. Okay, then type 2, in this epiphysis is separated with portion of metaphysis. Here we can see this type 2, here epiphysis, growth plate, and metaphysis. Some piece of metaphysis is also detached. Then type 3, epiphysis and portion of articular surface, where we can say the growth plates. Yeah. The articular surface, epiphysis with growth plate, but small portion, not the whole fragment. The whole portion is attached. Whole portion is detached. Just a small fragment is detached of from the articular surface or joint surface, and also the growth plate area. It is called type 3. In type 4, epiphysis with growth plate and metaphysis is detached. Same, if this fracture type 3 further continues to the metaphysis area, then it is type 4. Like type 1 is further affect the metaphysis, then it is type 2. If type 3 further affects the type 4 metaphysis, then it is type 4. In type 5, the physical growth plates are crushed due to, we can say, any kind of forces or any kind of physical forces which seizes the function of them, and they crush themselves to each other. Here we can say, in which the physical growth plates crushed themselves It is called type 5 Salter Harris. In this type of fracture, the function of the physical growth plate is totally seized off and the healing process is too much delayed. And this one is more painful. In type 6, if the trauma is V shape, the effect is V shape, then it is type 6. This type is not too much common, but the more common types are the above. But we should have idea about that. Now, symptoms of the fracture. What are if any area or any bone area, any area of the bone have fractured, then what kind of symptoms we can say on in that area? First of all, pain and localized tenderness. Due to pain, then deformity or change in angulation of that limb or that area of the bone. The angles are disrupted. Then abnormal mobility. The movement of the animal is also affected. In mostly cases, it is abnormal. Local swelling. Local swelling of that area. Mostly it persists 7 to 10 days because the blood supply of that area, the nerve supply of that area is damaged, due to which too much swelling or it's start from sometime it immediately start or sometime after several hours. Loss of function. If damage is too much, especially near the joints, and nerve supply is also compromised, and damage to the soft tissue is too much, then loss of the function of that area. Sometimes we have to amputate the limb. Cryptus. When we move the fracture fragments or the limb, we have cryptation sound. From that, we can confirm the fracture. The cryptation sound is something we have friction between the two fracture fragments. That type of sound is, we can say, cryptation sound or cryptus in that area. Diagnosis. Diagnosis is on the basis of history, clinical examination, the physical signs, we can say, on the basis of symptoms, then radiographic confirmation. It is better to take two radiographs on orthogonal views so that we can confirm the type of the fracture. Prognosis. It depends upon the type and location of the fracture, size and weight of the animal, the size, weight, and age of the animal. In young age, the fracture is treated earlier. Accuracy of the reduction and immobilization of the fracture. The reduction is important, how much you reduce the fracture fragments to the normal position, but also immobilization is important. If you reduce the fragments to their normal position, but still the movement is between them, they are not retained on their position, then it is affected, and the reduction you already done has no effect or no change. That's why they both are important. In general, the simple fracture prognosis is good, but as it is complicated, prognosis is dependent. I have to share one more PowerPoint, my PPT that is about internal implants. Here I have some shared some basic knowledge about fracture, its types, and more common types, and its symptoms and prognosis. Now we go with the internal implants, which are commonly
Okay,
used in pets. Sorry, here I have some problem with to share my screen. Is it okay now?
yes, we can look the slides, doctor.
Okay, thank you.
Maybe the view will be in slideshow. Will be much better.
Okay, internal fixation. Yes, I can change the view.
Okay.
Yeah. Okay. Firstly, I say we have two options for reduction of the fracture. I think I will also go through the internal fixation to sorry, wait a minute. Yes, we have two types or two options for treatment of the fracture fragments. Okay. Yes. Okay. We have two options for fracture treatment. One, first of all, treatment. How we do treatment? For treatment, we have principle, or I can say, if we achieve A and B, then our bone is treated or our fracture is healed. If A and B both are taken and both are affected. First, what is A? Reduction. The process of replacing the fracture fragments to their anatomical position, it is called reduction. To their normal contour, to their normal anatomical position, it is called reduction. It may be closed reduction, it may be open reduction. Uh, for closed reduction, we have some external fixation devices, and for open reduction, we have internal implants, which is today's our topic. For closed reduction, we did not open the bone or incise the bone, we just fix it from externally. While in open reduction, we have incision or we have surgery of that side, open the bone, and then do some implants over that. There are many kinds of them. Then it is open reduction. Immobilization. Immobilization, the main the main purpose of immobilization is that the reduction is achieved. If a movement is there, then the reduction you have done is not achieved. The fragments or the fractured line, they will move on to any parts or to any direction. If we immobilize, especially the joints above and lower side of the fracture, then the reduction is maintained more effectively. For this reason, we do different kinds of implants or different kind of things we use. The process of one important thing is that the process of bone healing cannot start unless the forces affecting of on them are not distracted or not controlled, they will be compressive, bending, or torsional forces. And our implants or our different immobilization techniques we use have need because of to we can say to expel these forces or to reduce these forces. For this, I say to reduce these forces, we have two kinds of implants. They may be external implants and they may be internal implants. In external implants, we have many choices like plaster of Paris, या POP bandages, polyester या polyurethane bandages, metal spoon splints, and external fixators. I just show you some pictures and then go to my today's main topic. These are plaster of Paris bandages. Then polyester or polyurethane bands. Some kind of these are other. Here is application of that POP and removal of that POP. These are metal spoons which are also used for external fixation to reduce the fragments. These are external fixation. Here is external fixation. External fixation is, I already said, there is no incision to the bone. We just fix it or we reduce the fragments from external side and then reduce the fragment on that area. There are some external fixation devices. Now I go to my topic, internal fixation devices. Just to link my topic, I just introduce the external fixation devices that we have idea about them. Now, internal fixation devices. We have many choices in internal fixation. Internal fixation, I already said that those devices which are used after surgery or with surgery or after opening of that area, those are internal fixation. In this, we have many choices. We can use them combinedly to or sometimes we use them separately. According to our choice, we can use them. First one is intramedullary pins or additional fittings. Along with them, they may be orthopedic wires, cerclage wires, or derotational plates. And they may be combinedly used or they may be separately used. They can use by both types. Then interlocking nails, they are again in the intramedullary cavity of the bone, but they have locking screws or they have screws on their on the extremities so that they cannot further move. Then tension band wiring, they are mostly used for avulsion type of fracture or fragmental fracture. These kind of wiring is used. Cross pinning, they are cross pinning is mostly used on the condyles or extremities of the bones where salter-Harris type fracture or we see articular fractures of the near the joints occur. On that areas we use cross pinning. Then bone plating are again used according to the type of fracture or according to the choice of surgeon. Then combination of different implants can also be achieved, in which we can combinedly use intramedullary pins with bone plates. We can also use intramedullary pins with wires. we can use K wires and cerclage wire as a tension band wiring. Then nails, interlocking nails with bones. I mean, we have choices in them. Intramedullary pins. Intramedullary pins effect on the bending forces of the bone, just on the bending forces of the bone. To for other forces, to neutralize other forces, we use additional fittings for them. They may be cerclage wires, they may be derotational for plates. I mean, for rotational forces, we use plates, or we can use cerclage wire or full cerclage wire or hemicerclage wire. Intramedullary pins are, as from their name indicates, they are used in the intramedullary canal or intramedullary cavity of the long bones. The intramedullary pins are mostly used, or they can be used in long bones, but we have two kinds for introduction of them, or implanting of them within the bone. They may be normograde fashion or retrograde fashion. The retrograde fashion is, yeah, retrograde method is only used for femur and humerus. Why? We see with this with pictures. Equipments needed: intramedullary pins, sharp at they may be sharp on both ends or one end. It is again your choice which kind of pin you want to use. Again, they may be threaded at one end. Threaded have good ability to achieve its reduction, or best, they have best bed in the bone. That's why you can use we can use threaded intramedullary pins, then pins chuck or Jacob's chuck with key to insert the pin, then pin cutter. After achieving our desired position, we can cut the extra pin. For that pin cutter, orthopedic hammer. If we have some compact bone piece, or we can't insert the pin with the Jacob's chuck or manual, then we can use orthopedic hammer. Then additional fitting devices, they may be orthopedic wires like hemi or full cerclage, or we can use different plates. Also, if wire are used, then wire twister and wire cutter. Here are intramedullary pins. They have pointed edges for insertion in the bones. Here are some instruments which I have already discussed. This is wire twister, wire cutter, again intramedullary pin cutter. This is cerclage wire, Jacob's chuck, and pin and detector. Now, what are two methods for insertion of the intramedullary pin? I already said normograding and retrograding. What is normograding? Insertion of pin into the medullary cavity from specific anatomical point. They may be on the proximal extremity, they may be on the distal extremity. I mean, if you insert the pin from the extremities, then it is normograde fashion. Here I have, yes, here is a video, picture about that, how we can insert the intramedullary pins in the long bone. From any axis, I say from any physial plates, from any extremity. They may be proximal extremity, that may be distal extremity. We can insert that pin into the intramedullary canal, then reduce the fragment, and then it is further pass into the other part of the bone. Here is surgical technique. As I already said, we give small incision at the selected point, then hold the pin into the chuck and start to insert it. Then when we go to the fracture fragment, the fragmental area or fractured area, then we reduce the fragment and insert it to the further part of the fractured bone or the other part of the fractured bone. If we have just insert the pin, then they neutralize the bending forces. For other forces, we need additional implants to neutralize other forces. Then is retrograding. In retrograding, insertion of pin through the fracture side. Again, it is only for humerus and femur because they are compact, they are nisbatan, we can say they are relatively strong bones than other. Here is method of retrograding. We put the pin in Jacob's chuck, then start to insert it from the fractured fragment area or fragmental area, fractured area, insert it from the till the extremity. It is out from the any area of the extremity which is desired from us, desired area. It is out from the desired area, then we open the chuck and put it on the opposite side. For one thing, for retrograding, we mostly use two-sided pointed pins. Okay, we insert it and took it out from the opposite side or opposite extremity. Then we remove the chuck from the area we start to insertion, then put it on the opposite side. Then we reduce the fragments of fracture or reduction is achieved. After reduction is achieved, we further start to pass it out. When we insert it to the desired location, we remove the chuck. We remove the chuck, and if needed, we cut the that area of the pin, and it is achieved. The reduction is achieved. But if you think they still have some kind of forces affecting of them other than tension forces, then we use other than bending forces, then we can use any kind of additional implants. Bending forces are compromised or neutralizes with intramedullary pins. For rotational and axial forces, we use additional implants like application of hemicircular wire. Hemicircular wire, as from its name, if it is passed through the bone fragments or we dig hole in the bone, we make hole in the bone, it is hemicircular wire. And if it is on the full cortex or full thickness of the bone, and we have circle of that on the bone, we can say we make circle of that on the bone, it is full circular wire. We have two options for circular wiring, for closing of that. We sometimes make a loop of that circular wire, then circulate it from the axis of bone, then the free ends or the opposite ends are passed from that loop and they are curved back so that bended back so that they cannot affect the surrounding soft tissue. One idea is that. The other is that we take single piece of that cerclage wire. In this we use double of that, or we when we make loop, it has two rounds along the bone. If we want just single, then we have this option. We make a circle of that and then twist the both part of that cerclage wire on the fractured line, and then cut the other pieces, and the cut pieces are then bended toward the cortex of bone so that they cannot affect the surrounding soft tissues. Application of cerclage wire with K wire or Krishner pins. They are also called K wires. They are also called Krishner pins. They are again used. They can be used in long oblique fracture or oblique fracture. They are also used in avulsion type of fractures where we use it with tension band wires. Here it is used in oblique fracture along with cerclage wire. There is a radiograph of full cerclage wiring along with intramedullary pinning. Here is intramedullary pin. It is inserted by normograde fashion. Okay, in normograde fashion, we have pointed edge on one side, and in retrograde, we have on both sides. Okay, and again I say in humerus and femur we use normograde fashion. If you are asked in this radiograph which technique is used about intramedullary pinning, then we can say normograde. Why we can say normograde? Firstly, we see the bone. It is not humerus, it is not femur. Okay, the other thing is we see the pin shape. The pin is pointed only on the one end, the other end is not pointed. Then again it is normograde fashion. Then it is used with full cerclage wire. Here we can see it is with full cerclage wires. It is there are two radiographs from different angles. Hope so it is understood. Okay, next is interlocking nails. Interlocking nails, they are also inserted into the medullary cavity of the bone or locked in the places with screws. They are locked at their places with screws. Okay, one thing I have to add in intramedullary pins, sometimes intramedullary pins have complication. One of their complication is pin tract infection, as they have pointed edges, or if the animal or if the subject over which we have implanted it, they move, or due to any kind of force they further pass it out, or sometimes they affect the joints area. For that reason we use interlocking nails. They are also have almost the same function, but they are locked at that areas by these screws, due to which they cannot further penetrate. And the other, due to screws, they neutralizes all the forces acting on the limb or acting on that fragment of the bone. They come in different sizes and lengths, and the holes, they may be 2 holes, there may be 4 holes. Again, it is your choice which kind of type you want to use. Okay, the distal end of the nail is pointed or trocar pointed, we can say. The pointed edge, which is used for insertion, which are equipments used for interlocking nails are, first of all, we have interlocking nails of different sizes. Size depend upon the intramedullary cavity size. Then drill guide jig for drilling and also for screwing. Drill guides, extension pieces, if needed, for insertion, nails, and drill. Here are some parts. Drill guide jig, drill guides, femurs, and intramedullary. These are intramedullary nails. Then we have surgical technique. These are interlocking nails. I already said they have holes at 2 points, one at lower, two at lower, and two at upper side. Sometimes one at lower. Application of interlocking nails. We we insert into drilling jig, then insert it from like if we combine the insertion of intramedullary pins and nail, then we insert it by normograde fashion from the extremities. Then extremities we start insertion, but for this the instrument for insertion is different. It is drill guide jig. After insertion, we achieve when we are achieved or when we are at the desired position, then we start screwing in that. Screws are mostly on the extremities. Again, two at the upper extremity, two at the lower extremity. How we can say which how all forces are neutralized by them. Again, here is insertion of the locking nails, and jig also helps us in insertion of nail and then screwing. By jig, we have idea about the holes in the screws, and then we pass the drill bits from that jig for making hole or making a hole in bone, and then that hole pass through the interlocking nail, and then the far cortex, this is the nail cortex. From you insert the drill bit, and the far cortex from you the drill bit is come out. Then we insert, we put the screws by the help of screwdriver. After achieving the correct position, it is seen like this form. They are connected on the two parts. Here is radiograph of intramedullary nail with full cerclage wire. It is one plane, mediolateral, or we can say it is interior posterior view of the same patient or same animal. Okay. Now I say how all forces are neutralized by interlocking nails. First, same like intermedullary pins, the bending forces are neutralized. Then the axial forces and rotational forces are neutralized by the help of these screws. The screws at different points help in bending, rotation and axial forces effect. So the all forces, or we can say bending, axial, compression, uh, what we say, uh, rotational, all forces are compromised. Then tension band wires, your tension band wire principle. This is used for avulsion type of fracture. The purpose is to convert the tensile forces into compressive forces. It is used mostly with the for making tension in that area, or sometimes leg screws are also used along with them. For this we can use Steinman pins or Kirschner wires or K wires along with them, with the cerclage wire or orthopedic wire, then cortical or cancerous screws or malleolar screws, any kind of screws we can use. Tension band principle, or how we can achieve it. First of all, we reduce the fracture fragments, the area where the fracture is occurred, it is reduced at its normal position. After achieving the normal or anatomical position, we insert two wires parallel to each other and perpendicular or above the fracture line. It is perpendicular to the fracture line and both wires are parallel to each other. After insertion of them, we dig a hole 1 to 2 centimeter below the fracture line. Here is that hole, or we make a hole 1 to 2 centimeter beneath the fracture line. After achieving that, we pass a orthopedic wire or cerclage wire from that hole, then make figure 8, or we make 8 of that, and we also pass it from that hole and from the bended or from that wire ends, so they make some kind of, we can say, uh, force or tension of that area, tension in that area, due to making figure 8, due to making 8 in that wire, and also when we twist the wire, it make too much tension in that area, due to which it is called tension band wiring. There is also another example of that with tension band wiring of the tibial tuberosity, in which we use K wires of that fragmented fracture, along with one part is also passed from the ligament or the soft tissue or attachment of that part. After that, we make figure 8 and twisted it, and our desired position is achieved. Again, how we use it for olecranian fracture or olecranian avulsion fracture, we pass two K wires perpendicular to fracture line, then dig hole 1 to 2 centimeter below the fracture line, pass pass the wire from it, make figure 8, then twist its free ends or circles, and then our desired position or desired alignment is achieved. Here is how it is used radiographically. Here is its example. Then fixation of avulsion fracture with screws and tension band wire. For screwing, we firstly use drill bits. Drill bit, or by drill bit, we make hole in the articular surface, or we make hole in the cortex of the screws, cortex of the bone. Then bone tape is used to make striations or threads in that area. After making threads, we insert the screw in that area, and the reduction is achieved also with immobilization of that fragment, because the tension is too much in that area. Then is avulsion fracture, mid-malleolus tibial fracture. It is seen here. It is achieved by bone plates and with the help of screws. Also, some K-wires are also inserted. Cross pinning, mainly used for supracondylar fractures like Salter-Harris type 1 fractures. Stability is providing 2-point fixation at different angles. We cross the two pins in this. Mostly the pins used are K-wires. Here is its example. This is type 1 Salter-Harris fracture. Here the growth plate, is detached from the from epiphysis and metaphysis area. We reduce it according to its normal anatomical position. Then we cross pin it. One pin is inserted from one articular surface at its axis, and then it is passed from growth plate, then metaphysis, and opposed at the opposite end. Then again, it is inserted from the opposite. From that, we can say one is inserted from medial condyle and opposed crossed growth plates, then metaphysis, and it is out from the metaphysis of the lateral side. Then the other pin is inserted from the lateral condylar area, and it passes growth plate, metaphysis, and out on the medial side of the other cortex. They both mostly cross at the fracture line. The cross pins mostly cross each other above the fracture line. After that, the extra pins are cut out. And one thing important for cross pinning is that our insertion is from articular surface, and then we bend the outer points of that. Due to bending, they did not affect the articular surface or joint area of this, and the pointed edge of that pin is also cut off after insertion or achieving the after coming out from the other cortex of the bone. Then we sutured the joint capsule, which we have opened for insertion of pin, and we close our surgical site, and our reduction is achieved. Now immobilization. For immobilization, we have used different implants. Now I also go through some bone plates. I think my lecture is lengthy. Okay, now the last one, the bone plates. How we use bone plates? Many kinds of bone plates can be used. They may be dynamic compression plates or DCP plates, LCDC plates, or there are some types of that. LCDCP plates, then Sherman plates, broad plates, narrow plates according to their width, then reconstructional plates for bending or for movement, then locking plates or T plates. Again, they are used according to the area they are used, or according to the surgeon's choice, which kind of plates you want to use. Okay. Then cortical screws. Two types of screws are mostly used with plates. These may be cortical screws or they may be cancellous screws. For cortical screws, we have to use bone tabs for making threads in the bone, while in cancellous screws, they are used untapped area because they have high pitched threads. They can tap by themselves, and then they make their threads or their striations by themselves. Again, the size of the screws depend on the plate you are using. According to the plate, if you are using 2.5 mm DCP plate, then you can use 2.5 mm canceller screw or cortical screw, any kind of screw. For this bone plating, we have some other implant equipments used, like bone clamps, which are used to hold bone, then Loman bone holder to hold bone and also the plate, then electric hand driven drill machine to drill the hole for screws. This one is electric and this one is hand drill. Load guide for drilling. These are drill pits for digging hole in the bone. Depth gauge to measure the depth of the hole, which are used, which are according to the screws length. Drill sleeves again help for tissue protection. For drilling, the drill bit is passed from it, and these notches are fixed on the bone so that our drill bit can't move on the bone, and drilling is achieved by not making injury to the other tissues. This one is bone tap. It is again used according to the screws used, or which size of the screw used. According to that, we use bone tap. Has screwdriver are again chosen according to the top of the screw. if we again go to the screws, this is the screw top, and screw top is yeah, this is the screw top. This one is hexagonal, and I think this one is from this picture it look like, see, it is pentagonal. They may be straight screw tops, they may be hexagonal, they may be tetragonal. According to the screw type, we can use screwdriver. Which kind of screw is used? We use screwdriver according to that. This one is screwdriver. Bone plates. We use bone plates and bone screws according to their size. If we are using bone plates, or which diameter of bone plate is used, according to that drill bit is used. If the diameter of screw is 1.5, then drill bit 1.1 and 1.5. We mostly use drill bit smaller than that. Then use bone tap according to that, and then screwdriver according to this. Same like mini screws, small screws, large screws. Which screw is you are using? The main thing is that drill bit is smaller than that, and bone tap is according to that, or same to that. How will you do bone plating? First of all, we reduce the fragmental area of the bone. The after uh, fragmental reduction of the fragments, we put the bone on we put the bone plate on the bone, and from the holes we start uh, drilling of by the help of hand drill machine or electric drill machine. We dig up a hole in the cortex of the bone or in the long axis of the bone. After making hole in the long axis of the bone, we bone tap according to the size of the screw. After bone tap, we use a screw, and then according to that screw, we use screwdriver. After insertion of the screw, we tight it, or we fix it with the help of screwdriver. Firstly, at one area near the fracture line, we can say near the fracture line from the lower side, and then the upper side, not on the fracture line. We cannot screw upon the fracture line because that one is already damaged, and due to screws we further make a hole, or we the fracture fragments or the reduction is not achieved. For achieving of reduction, we insert one side of screw but did not tight it, or did not fully tight it. After insertion of the other, it is then locked or tight according to your desired position. Then tight the other one. After making it tight according to your need, your fracture fragments are reduced easily. If you firstly tight this one, then tight this one, it your desired reduction is not achieved. So just insert it and fix it, but not too much tight it. But after insertion of the other, make it tight according to your desire, and after that make it. By this, the fragments are reduced and your desired reduction is achieved. Okay, same how the bone plates affects. They affect the axial forces. They affect the bending forces. Oh, sorry, rotational forces. If they are used with pins, then they also neutralizes the which I say rotational forces. If they are combined with intramedullary pins, they also neutralizes bending. Otherwise, they affect rotational and axial forces. So that's why we combine different implants so that we neutralizes all forces and our principle for reduction is achieved, like reduction and immobilization. Okay, thank you.
Thank you, Dr. Farah. It's very interesting topic with a long presentation, but
Yeah.
I
I
hope the
think I
topic
make it too long. Sorry for that.
it's okay, but I think the content is very interesting because the students also studying about the fracture maybe in the future, yeah, in the next semester. So
Okay.
I hope it will give them a lot of information.
Hope so.
Dr. Farah,
Yes.
first, after this we have a discussion session, yeah.
Okay.
But maybe the time is quite limited, so maybe around 15 minutes. First of all, I also would like to say hello to some one participant who raised. Oh, I think the person left already, Dr. Mizaya. Yeah. The
Uh-oh.
person is not in it. Yeah, because the first time when you finish your first file, somebody has raised hand. The name is Professor Dr. Iyah Tasham Khan.
Okay.
Yeah. Do you recognize the person, doctor?
Yeah, it is from, I think, our university from Pakistan.
Oh, I see. Okay. So I would like to say hello, but I think the professor is not joined in this Zoom meeting right now. So I would
Okay.
like to give opportunity to all of the lecturers or students, the participants in this guest lecture, to
Yes.
deliver the questions,
Yes.
either in the chat box or you can just turn on your microphone and directly asking Dr. Farah. Any questions, participants? Hello. I hope all of the students are not sleepy right now.
Yeah, hope so.
There
Okay.
is a question, Dr. Kiki.
Yeah. So we have a question from
Yes.
Amir Seza. He asking about how much time is required for a bone fracture after wiring.
How
So maybe
much
you can
time?
directly answer the question, Dr. Farah.
Sorry, can you repeat it?
Okay. How much time is required for a bone fracture after wiring?
Okay. Normally, after any kind of implants, we minimum required 5 weeks, and again it depend upon the animal, its age, its weight, and environmental condition. But minimum time required is 5 to 7 weeks. It can be more than that, maybe 2 months, or if the age of your patient is small, we can say. In early age, the fracture sorry, the healing is achieved so earlier, in early age, young age, we can say.
Okay. Is it clear, Dr. Amir?
So, yeah, is it clear?
Hello, Dr. Amir.
Thank you, ma'am. Yeah, I am clear that I wanna just ask the time of the fracture for healing. So I am
Okay.
very thankful.
Thank you.
Okay. Any other question from the students or from the lecturers?
Yeah, there is question,
Participants
Dr.
in
Kiki.
here?
There is question from a student in the chat room, directly to me.
Oh yeah.
Okay,
Who
from
is the student?
Ahmad.
Who want to directly asking? Is it?
There is a student sending questions from direct message chat to me.
Oh, okay. So maybe Dr. Riza can
Yeah,
read the
I will
question.
help to read. Okay, so from
Yeah.
Ahmad, the question is about bone plating. About the measuring of plate that will be needed for the surgery. Is that from the radiograph or the actual measuring in a surgery table? Also, there are the second question.
Yes.
After the operation, how many months needed for evaluation? And from the radiograph image, how long it will takes if the result is malunion? What's your recommendation? I think that's the question.
Okay, I think which I understand. Um, if I think the student is asking about the size of the bone plate and also of the healing time.
Yes, the size of the bone plate. How to measure the size by the radiograph or directly on the surgery table?
Okay. And the size of the bone plate is again according to your choice. The size of the bone plate is measured according to the holes. How much hole the bone plate have? We can say we can use 4 hole plates, 6 hole plates, 8 hole plates. For normally for long bones, we use 8 hole plates, especially for femur and for humerus. For tibia and for radius ulna, we normally use 6 hole plates. Again, it depends upon the animal. If the dog is large dogs, then we use according to them. We measure the size of the plate according to the length of the bone, and this size is according to the holes of the plates. How much hole one plate have, and the healing time again, the minimum healing time will be 5 weeks, 5 to 7 weeks. And I think one question is about radiograph. Normally we can take radiograph after 1 week, 2 week. Again, we can see the healing process. We can say soft callus, then uh, uh, spongy bone formation, then compact bone formation. We can see it at different episodes. We can see it at different intervals. We can take started from first to second week and till 2 months. Hope so. He can understand. Or I understand his question.
Okay, Dr. Miza, maybe for the second questions. Is there any question on the direct message? Because I cannot read anything in the chat box. Yeah.
Yeah, I also can.
Okay, I think Ahmad said thank you. So I assume that he understand your answer, Dr. Farah. Is there any other question, maybe Dr.
Yes,
Miza,
there is
on direct
question
message?
in that, yeah, via direct message from, wait, Tong Suchun. Is there any alternative treatment for osteosarcoma animal, and is it possible that there's a higher chance of bone fracture happening in other parts of the body with osteosarcoma patient?
Can you repeat it again?
Yeah, I am clear.
Pardon?
I wanna just ask the time of.
Can you
Can you
repeat the
repeat it?
question, Dr. Miza?
Yeah, it's about osteosarcoma. Is there any alternative treatment for osteosarcoma animal? And is it possible that there is a higher chance of bone fracture happening in other parts of the body with osteosarcoma patient?
Osteosarcoma. I think
Yes.
they are asking about osteosarcoma. Yes, for osteosarcoma, if we have too much damage to the bone, then we have option for implantation of new bone, or some parts of that we can say affected part is replaced by the artificial bones available in market, or they are available for changing of that part. I think he's asking about that. We can replace it with artificial part of the bone
The second question,
in osteosarcoma patients.
after the operation, how many months?
We can cut it, that part, we can remove that affected part, and then it is replaced by artificial bone. Is it clear?
I hope it's clear, yeah?
Yes, I think
Sorry, Dr. Miza, who is asking? Is it students?
I hope I read the name right. Okay, Tong Suchun.
Suchan,
Yes,
yeah. So
student.
if I repeat the answer, so usually we can take the artificial bones to take over the bones that affected by osteosarcoma.
Yes, the student already said thank you. I think it very clearly understand the answer.
Okay, so from the everyone's chat box, yeah, there's a question from Dr. Saifur Rahman. He asking about the bone fracture when we do the plate fixing. How much distance is required from the fracture? Is it clear, Dr. Farah?
Sorry, can you repeat it?
Okay, so Dr. Saifur Rahman asking about the bone fracture. When
Yes.
we do a plate fixing, how much distance is required from the fracture? The distance.
From fracture line.
Yes, I guess. Yeah, from fracture line.
Mean he's asking how much we need distance from the fracture line.
Yes, for the plating method.
For the plating method, how much
Yeah, plate fixing.
distance? Okay, how much distance we can take from the fracture line?
Yes.
Okay. When we are plating, we have different holes in the plates. Okay, normal distance from fracture line is 0.5 sorry, half centimeter or more than less than 1 centimeter. Okay, if the distance is less than this, the fracture line have further fragments or further effect on this, and the gap between the fractured area is higher. And if the distance is more, then the reduction is not achieved according to the need. The when we tied the screws, reduction is not accomplished. That we say according to the distance of the hole, we can impede 2 holes near the fracture lines, and after that we screw other all holes of the bone plate.
Okay.
At least a safe distance, I can say safe distance is at least of 1 hole. 1 screw's diameter or 1 screw hole diameter is the safe distance. If they have idea about the bone plate, if they see the bone plate, then let me see if my presentation is open. According to that, I explain this. Wait.
Okay, Dr. Farah. Maybe I would like to ask Dr. Saifur, is it clear? The answer from Dr. Farah?
Yeah.
Yes, thank you very much. It's so clear. Thank you very much for your answering.
Okay.
Okay, thank you.
Yes, you're welcome,
Yeah.
Doctor.
You're welcome.
Okay, so maybe I would like to hear the voice from one of participants. Maybe you can try to directly deliver your questions in this event right now, or maybe Dr. Mirza has one more questions from direct message.
There's still no question in direct message room. So maybe the
Okay, so
participant can ask the speaker
yeah,
directly.
I assume we have undergraduate. Oh, okay. So we have Nadifa. Nadifa, do you want to give a question to Dr. Farah?
Yes, but I'm really sorry I
Okay,
couldn't
please.
open the video.
Okay, please, Nadifa.
I would like to ask about the post-operative care and assessment. So I read in the literature that activity should be restricted right after the surgical procedure. It is in order to limit the walking until the fracture has healed. But I also ever know about the physical rehabilitation after surgery. Like, I feel like it's to encourage the controlled limb use and to optimize the limb function of the fracture healing as well. So the thing that I want to ask is that what is the right time to do the physical rehabilitation? Is it after the 5 until 6 weeks after healing, like as been told before, or is it during the 5 until 6 weeks of healing?
Okay, thank you, Nadifa. Dr. Farah, you can hear the question clearly.
If you repeat it, I just understand. I think something about healing time.
Yes, so the students, she asking about what is the correct time to do a physical rehabilitation after the surgery?
Yes. Is it like during the
So
5 until 6 weeks? Or...
Sorry, can you repeat?
Yeah, for the physical rehabilitation itself, is it done after the healing? I mean, previously it said that the healing time needs 5 until 6 weeks. And for the rehabilitation itself, so it's like after the 5 until 6 weeks or during the 5 until 6 weeks of healing?
Yes.
So maybe I would like to add some information, maybe for make it clear. When we can train.
Sorry, I have.
When we can train the patients after they are having a surgery. So just to make them walk or make them run or something. So when is the physical training can be started after the surgery? I hope that is the question, Dr. Farah.
Sorry, I have some irritation in my throat.
Oh, okay.
Yes. We can allow movement normally about healing. But again, it also depends upon damage to the tissue also. If damaged too much, when we have discussed some types of fracture in which too much damages occurred in different soft tissues, then we restrict movement for some more time. Normally, we allow movement after 2 to 3 months, meaning after healing. But if the damage is too much to the soft tissues, we restrict it for some more time. Hope you can understand.
Yes, thank you for the answer. Maybe do you want to drink some water first, Dr. Farah?
Yeah, I take. Thank you.
Yeah, okay. I hope Nadifa can hear the answer clearly. Yeah, Nadifa?
Yes, Doctor. Thank you so much for delivering such an interesting topic and also answer.
Thank you.
Thank you. And then during discussing, I saw someone was, I think, raising her hand. I think the name is Fatia. Fatia, do you want to deliver a question directly to Dr. Farah? Hello, Fatia. Or just accidentally press the reaction maybe. Yeah. Okay. So any other question from students? Nadifa is our program students. Yeah. How about the undergraduate students? Is there any of you who would like to deliver the questions? Okay, if not, so maybe I would like to end this main agenda for this afternoon. So we would like to say a lot of gratitude. Thank you so much to Dr. Farah for sharing a very interesting presentation. Yeah, and maybe I would like to give it back to Dr. Mirza.
Okay, thank you, Dr. Hardani. Before we end this session, how about we turn our camera on and we take a photo session for a moment? Yes, before we end this session, please turn our camera on and we will take a photo session. Okay. Okay, there will be eight page. So for the first page, on my cue, 1, 2, 3, and cheers. Okay. Wait for a minute. For the second page, 1, 2, 3, and cheers. For the third page, 1, 2, 3, and cheers. Okay, thank you. Okay, thank you for for joining this session, and thank you for Dr. Farah Ijaz, thank you for Dr. Hardani Primariski, and all the others lecturers that attend this event this afternoon. I hope we can learn so much from today's event. So I will close the session. Thank you for joining and stay healthy. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you. Allah Hafiz to all.
Thank you, Dr. Mirza.
Thank you for all.
Thank you, Dr. Farah.
Thank you. Allah Hafiz.
Stay safe and healthy to everyone.
Yeah.
Be healthy and be
Dr. Farah has a throat infection, but she continued his lecture. Thank you, Dr. Farah.
Thank you, Dr. Ahmed. Thank you all.
Matur nuwun Dr. Kiki, matur nuwun Dr. Mirza, matur nuwun Dr. Ira.
Sama-sama, Dr. Nana.
Oke.
Sehat-sehat semuanya.
Oke, sehat selalu.